Good day, everyone. Welcome to the webinar, The Support Act, Past and Present, Is It the Future? If you're experiencing sound or technical issues, I will address it after I'm done talking. My name is Angie Fiedler Sutton, and I'm with the Behavioral Health Association of Providers. The Behavioral Health Association of Providers, otherwise known as BHAP, is a national trade membership association that provides education and advocacy for behavioral healthcare providers and related entities. Formerly known as the American Addiction Treatment Association, BHAP is the leading and unifying voice of addiction-focused treatment programs. We provide membership opportunities such as networking and various benefits, education opportunities such as this webinar on our Certificate in Addiction Treatment Marketing, CATM, and advocacy efforts to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Our member benefits include discounts on our educational offerings, access to our compliance documents, and more. But a membership in BHAP gives you something everyone finds valuable: time. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever-changing information for compliance. BHAP gives you the resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about BHAP, you can visit our website at www.bhap.us. Before we begin the webinar, a few housekeeping details for those of you joining us for the first time. You will be able to hear us, but we won't be able to hear you. That's because we record these webinars so you have access to them later if you need them. However, if you have questions or concerns, you can use the chat room on the lower left. You don't need to wait until the end for questions. We will be sending the PDF of the slides as well as a link to the webinar after the event. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is a founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. With 20 years of policy experience and over a decade in behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, the Substance Abuse and Mental Health Services Administration, and other federal actors. Kessler has written legislation in report language adopted by both the House and Senate Appropriations Committee and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College of on Problems and Drug Dependence. He's also BHAP's advocate in Washington, D.C. If you are a BHAP member, one of your benefits is access to a monthly call with him to hear about and ask questions about upcoming legislation that may impact the behavioral health industry. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and good afternoon to those of you in the East. Good morning to those of you in the West. It's my pleasure to be here with you today and to talk about the Support Act. We are going to talk about this legislation, how it came to be, what its impact is, and what its prospects for the future are, which is really the main point. How are we going to proceed from here? Just a word about how I present. You will see some information on the slides, of course, but what I'm going to tell you is going to go into much greater depth than what is written. There's a lot of complicated ins and outs, a lot of information on the legislative process and how we got here. And I just wanted to warn you that it's going to get a little technical, but I'm going to try and keep it in such a way that I keep all of you with me and on track. So with that, we'll get started. Angie already introduced me. I've been in Washington for 26 years, and I've been in public health policy for almost 20. I am one of a few people who work specifically and exclusively on substance use disorder issues in Washington, D.C. So this is pretty much all I do, and I'm pretty comfortable with the subject matter. So there's a lot of information to share. So I want to start with a little history. Before we get to the Support Act, there's just going to be a few slides on how we got to the Support Act, because I'm a big believer in you don't know where you're going until you know where you've been. Obviously, the Support Act was not created out of thin air. There are origins, there is history, and I want you to be familiar with that, because that's the foundation we build on. That's how a lot of legislation works. You're always building on the last piece of legislation, whether you're talking about anything in healthcare, anything in pretty much any aspect of legislation, whether it be civil rights, labor programs, justice programs, whatever it may be. You're always building on what was done previously. So I want people to be familiar with that history. And where we're going to start is about 12 years ago, even though there was, legislation. We only have an hour, so I can't give you, I can't go all the way back to the original Narcotics Control Act, but we're going to start with Wellstone Domenici in 2008. Many know this by another name, the Mental Health and Addiction Parity Act. This was several years in the making and literally decades in the making. And what this bill did was this bill established that if an insurance company is going to offer substance use disorder or mental health benefits in its care program to its customers, they must be offered at an equal level to general medical and surgical benefits. A lot of people misinterpret parity and they think it means that when insurance is offered, that substance use disorder and mental health services must be offered too. That is not the case. With parity, what it does is it offers parity in the sense that if 80% of all medical and surgical costs are covered, then 80% of all behavioral costs are covered, and on down the line. What insurance companies used to do was offer, let's say, 80 to 90% coverage on general and surgical, but only 30% on behavioral. They can't do that anymore. So the Parity Act was one of our first major landmark wins of the 21st century, and that was in 2008. That kind of set the stage for our progress with the Affordable Care Act in 2010. In the Affordable Care Act, what was listed were what we call minimum benefits. And this was an area of 10 areas of healthcare that said any plan governed by the ACA, which would include Medicaid expansion, the exchanges, anything statutorily defined to fall under the ACA's governance, had to offer substance use disorder treatment and recovery services as a minimum benefit. Now, here we are 10 years later, we're still trying to figure out exactly what that means, because what does that mean? When it says you have to offer substance use disorder treatment services, does that mean inpatient? Does that mean outpatient? To what level? To what expense? Does that include MAT? Does that, so we're still trying to figure all of that out. When it comes to both parity and the ACA, there are still cases in federal court trying to figure out exactly what that coverage entails. When it comes to insurance, which is what the ACA and the Parity Act govern, insurance always plays out in the courts. You never know what legislation is going to cover until the courts have their say. So we're still trying to figure out exactly where we stand with legislation that passed 10, 12 years ago. I think you see where I'm going with this. For legislation that passed more recently, it's going to be a long time before things shake out, but we'll get to that. Then the next big piece of landmark legislation was CARA, the Comprehensive Addiction Recovery Act. And this came into being in 2016. This was the first standalone piece of legislation to be considered by Congress and pass Congress that dealt with substance use disorders since 1972. Okay, this was the piece of legislation that was Congress's first major standalone response to what we have now branded the opioid epidemic. Those of you who work in this space know that the opioid epidemic has been around a lot longer than the media would like to pretend it's been. But when there started to be a groundswell of support on Capitol Hill for doing something about the opioid epidemic about 6 years ago, CARA is the legislation that was kind of born out of that. Now, because we were still in an environment with a Republican majority in Congress and a Democrat in the White House, and the two sides were still going back and forth over the ACA, It was very difficult to get landmark healthcare legislation passed. So what those of us who worked on CARA did is we went a different route, and we went through the criminal justice system. A lot of what CARA did was it made reforms to the criminal justice system in order to reframe how policymakers view substance use disorders, take it out of the criminal justice penalty approach and put it more towards a treatment approach. CARA was widely successful in terms of its legislative record. I believe it passed the House by a vote of 405 to 5 or 6. I believe it passed the Senate 98 to 1, something along those lines. And it was signed into law by President Obama in 2016. It was written and passed pen to paper with the first original idea, and then passed in a span of about 3 years. I can't emphasize how fast that is in Washington, D.C. That is light speed. Washington does not respond quickly to public health crises. Hint, hint. You're seeing some of that play out right now, but that piece of legislation was considered quite a victory for those of us who work in this space. No sooner had CARA been passed than the 2016 election took place. We got a new party in the White House, and advocates started to think, okay, what's next? Obviously, CARA was a big step forward, but we've got to build on it. It's legislation is kind of like a great white shark. If you stop moving, you die. You've got to keep moving forward, keep building on what was the last success. Okay, so we looked at what CARA brought us. It brought us some interagency cooperation. It brought us grants to reduce overdose. It boosted some NIDA research. It established some grants for expansion of medication-assisted treatment. So it picked a few spots, few different grant programs, and said, here's where we see the top priorities. But we started to want to say, okay, how can we establish a change in the system? How can we, at the very root of the system, start to enact change rather than just picking spots here and there, like overdose, like research? We started to think about that, and we started to realize that the more we worked on this issue, the more of a political football it became. When I started working on this issue back in 2004, nobody, very, very few people on Washington made it their primary issue or were really interested in it or really understood it. A lot of what we had to do in Washington was educate lawmakers, teach them about the disease of addiction, teach them about treatment protocols, teach them the value of recovery. And there were some that listened. But flash forward to the environment in about 2017, and the opioid epidemic was, and I say this with great confidence, without a doubt, the top policy issue in Washington, and not just in healthcare. Number one, no one could walk into their office without their phones ringing off the hook in their home district saying, what are you doing about this? And that's what drives legislation. Unfortunately, when that is the situation, you have to shift from it being issue-based and policy-based to politically based. There is a big difference between politics and policy. Policy is what I do every day. Can we write laws? Can we get grants? Can we do what we have to do to establish policy so the federal government can address this issue? Politics, completely different. That is members of Congress and the White House saying, look what I did for you so you can reelect me. Big, big difference. And when policy and politics collide, okay, You have a game we call political football. Your issue becomes what we call a political football. And people start caring less about the actual issue and more about the political optics. And that's where we were when the Support Act started to come together. Okay? Originally, it had the working name of CARA 2.0. The idea started to be hatched as things calmed down from the election in 2016. Starting in the winter of January 2017, we started to say, hey, what can we do that's more, as I said before, we're riding the opioid wave, and you'll remember what I said a few minutes ago. We wanted something, the advocates wanted something that implemented a systematic change. How the healthcare system can deal and treat substance use disorders, and specifically the opioid epidemic. Okay, so that's what we wanted. Of course, when politics enters into the picture, everyone who wants to be a part of this has their own little idea of what it should look like. Okay, and that's when legislation starts to evolve. It morphs. There's a saying, I don't know if you've heard it. If you haven't, you're going to hear it today. There are two things you never want to see being made: sausage and legislation. Why? Because they're both messy, and there are things that get into the mix that could make your stomach turn. Okay, so when we make legislation, we have an expression: we're making the sausage. Okay, and as this legislation was being made, it got bigger and bigger and bigger. Why? If you keep stuffing the sausage into the casing, it's going to get bigger and bigger and bigger. And there's another metaphor we use, which is a Christmas tree. This legislation, as you're getting the sense, as it got bigger and bigger and bigger, became a Christmas tree. What is a Christmas tree? It's got lots of pretty things on it and lots of gifts underneath. And if you want something on the Christmas tree, you just hang it on. You find an empty branch, you hang it on, and you've added your ornament to the Christmas tree. Members of Congress just started adding and adding and adding. Okay? Why? Think back to what I said about the political situation. As soon as the 2016 midterms were over, and you start getting into the winter and the spring of 2017, what do members of the House start thinking about? Midterm elections. And now the Republican majority had a Republican in the White House. And what usually happens in midterm elections is that the party in the White House loses seats. So Republicans in Congress started getting concerned, what's going to happen in the 2018 midterm elections? Well, I've got to show my constituents I'm working on issues that matter to them. What was the number one issue that mattered to constituents in the spring of 2017, especially in heavy Republican areas like West Virginia, Kentucky, Tennessee, areas like that? It was the opioid epidemic. So politicians saw an opening to start putting their decorations on the Christmas tree. Okay, and like I said, it was a political football, and it was game on. What started to happen was everyone started to write their own legislation. I mentioned making the sausage. When sausage is made in DC, everyone doesn't come together and say, okay, there's one piece of sausage and I'm going to add my little ingredient. What they do is everyone makes their own sausage and it starts to come together. So people in Congress, members of Congress, started writing their own legislation. Very, very short. When I say legislation, a lot of people are intimidated. They think of these grandiose documents that are so difficult and complex. The average piece of legislation that started to be written during this process was no more than 3 pages. Some were even a page and a half. Because what they did was they established pilot projects. Every member of Congress had a different idea how to address the opioid epidemic, whether it was prescribing practices, whether it was monitoring prescribing, whether it had to do with pharmacists, whether it had to do with doctors, whether it had to do with reimbursement, whether it had to do with Medicare, whether it had to do with courts, whether it had to do with youth, minorities, pregnant mothers, veterans, you name it. Every member of Congress who wanted a piece of this found their own little niche, wrote their own legislation. At one point, there were over 75 pieces of legislation floating around concerning the opioid epidemic. Now, you'll see at the top of the slide, take into account, if you were to take just the legislation that was Medicare Part B coverage and just prescribing practices, you would have had about 39 of those pieces of legislation. Okay? So right there, instead of 75 pieces of legislation, 2 pieces of legislation could have addressed the bulk of the issues being addressed. But we don't do that because everyone had to go home to their district and say, look what I am doing. I introduced this legislation. Again, this is where the politics is colliding with the policy. And I feel safe in saying that every single Republican who lost a seat in the 2018 midterms probably had a piece of legislation on the opioid epidemic in an effort to go home and show their constituency that they cared about this issue. Every single vulnerable member of Congress wrote something. Now, I don't want to be too cynical, and I don't want to give you the wrong idea. There were many pilot projects and many pieces of this 75 pieces of legislation that were well-intentioned and good and well thought out and written by people in Congress who truly do care about and understand this issue. But I'm here to give you the big picture. And in the big picture, what we had was bill after bill after bill that just addressed one small aspect and created what we call a pilot project. Now, what's a pilot project? A pilot project is a grant program with a limited shelf life. The best way would be to, as an example, would be to maybe compare it to something you might be familiar with. Take, for example, the SAMHSA block grant, the SAPT block grant. That exists through statute every year. It, rarely has to be renewed. SAMHSA, the agency itself, has to be reauthorized, but rarely does Congress have to do anything to keep the block grant going. That is a grant program that's just going to continue and continue and continue. A pilot project has a shelf life. So when the legislation is written and says, we authorize for fiscal years 2020 through 2024, $1 million be allocated to do this, that's a pilot project because it's got a limited shelf life. And the reason we call it a pilot project is you're basically floating a trial balloon. Let's see if this works. We're going to give this program 5 years. We're going to fund it. Let's see if it works. That's why it's called a pilot project. So these 75 bills, almost all of them establish new pilot projects. Okay? So there was a variety of subjects within these pilot projects. Like I said before, there was recovery, there was prescribing, there was Medicaid coverage, there was MAT. Everyone had their own little pilot program. And the key was now to bring it all together into one piece of legislation. There we go. This is just an idea, a smattering of what these pilot projects entailed. This is basically I lifted this from the actual legislation so you can see it. I apologize for the small print, but this gives you an idea of the wide range that we were dealing with: peer support, enhancing patient access to non-opioid treatment, barriers to care, moms and babies, newborns, studies, blah, 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 on down the line. This table, as you can imagine, went on for pages and pages and pages of all the different programs that were being created in the Support Act. So this was each different office coming together and trying to assemble all of their moving parts into one piece of legislation. So the law passed, and not without drama. I don't want to, I don't want to make it sound like this was an easy process. There were hearings. There were what we call markups, where they review it. What goes in? What gets to stay in? What gets taken out? What's more important? What's less important? That whole process, took about, as I said, if we started this in January, February of 17, by the spring of 18, we had an idea of what it's gonna look like. So the law passed, I believe, in September of 2018. Went to the president. The Support Act passes. And for those of you who are curious, SUPPORT stands for Substance Use Disorder Prevention that promotes opioid recovery and treatment. I sometimes joke with my friends that one day I want that job. You tell me what the law is, and I'll come up with an acronym where the initials spell out what you're trying to do. I don't know where they come up with them sometimes. So the Support Act passed. It was known by its bill number HR 6, and the law passed. And you might think, okay, well, that's cause for celebration. Well, that's only the first step in the process. And here's why. Remember all those pilot projects I mentioned? Just because they were established by the Support Act does not mean that they now exist. And it certainly does not mean that they are funded. Okay? Because we can't confuse a law that authorizes a new program. What a law does is it creates a new program. It authorizes it. If it calls for funding, that is an entirely separate process known as appropriations. So now what we are faced with is a law with over 70 different pilot programs, each one of which needs its own appropriation moving forward. So that means an advocate like myself or my colleagues that I work with, let's say, for example, there's a program, Program A, and it says we're going to establish this program X million dollars for Y number of years, and the law passed. First, you have to hope that this program is mentioned in the president's budget, which the White House releases every year in February. Okay? If it is, good for you, and you have to hope that it's the amount that you want. Then you have to go to the House of Representatives as they do their appropriations process and talk to the people in the House and say, we need this funded at this level, and here's why, and do all of the work that goes with that, filling out forms, making your case, so on and so forth. Then start the whole process over in the Senate. Go to the Senate appropriators. Tell them why this program's important. Nothing is more appropriators. Tell them why this program's important. Nothing is more important than the first year of appropriations in a new program. So all of these programs in the pilot project, if they don't get funded in the first year, you could pretty much forget it. It's not going to happen. Rarely do they go back and say, oh, this was created 3 years ago, but it was never funded, so we're going to resurrect it now. Also, if it's not in the president's budget the first year after it's created, you've got a very long road ahead of you in Congress. So what this Support Act did was really just create a whole new level of advocacy that we had to undertake to make sure all the pilot projects in it would now be funded. Okay? And the process is not short. So imagine, if you will, September of 2018, and the law is passed, and you say, yay, the law is passed, my program is now a reality. You've got to wait until February of the following year for the president's budget to come out and see if that program was proposed for funding by the president's budget. Then you go into March, and you've got to wait until, the House goes through their thing and the Senate goes through their thing. With any luck, if the process works perfectly, hint, it doesn't, and the appropriations process is completed by September 30th of the following year, which it never is. We've been, if you follow the news, you know that there are continuing resolutions and delays and shutdowns and, you know. So let's say, for example, best case scenario, there's a 3-month delay in the process, and finally, in December of 2019, the money is appropriated. The appropriations bill is signed into law, the new fiscal year has begun, and the agencies have the money. Wait, we're not done yet. Now, the agencies have to decide for this new grant program what the grant will look like. They have to create the grant program. We are going to give out money to entities that fit these requirements and propose, you know, all these different ways of meeting the goals and what have you. If they're really quick on the trigger, that takes a couple of months. So you're now into March of 2020. You have to send the grant out. You have to wait 3 months for proposals to come in. We're into June now. And finally, then they have to decide. That takes another 3 months. And we're possibly into September of 2020. So from this bill signing into law to the money going out to the programs where it becomes reality, 2 years. If everything goes according to schedule. You have to wait for the budget. You have to wait for the appropriations. You have to wait for the grant to be written. You have to wait for the applications to come in. You have to decide who won the grants. You have to distribute them the money. Okay? 18 months to 2 years. So when you see that a law like the Support Act is passed and you say, wow, this is great, you have no idea what what kind of process is about to unfold in front of you. So we are just now, so this passed in September of 2018. I track this very closely. I am just now seeing grant programs start their solicitation for the programs that were created by the Support Act. We are in March of 2020. So it's been 18 months since the bill passed, and we are just seeing the grants start to be solicited and the first bit of money going out the door for the Support Act. Okay, now what is this money? What was in the Support Act that people, members of BHAP, might be interested in? If you've been listening to me up to this point, and you're trying to get a sense for, how I feel about this process, you might think, wow, he's really fed up and it wasn't worth it or what have you. That is not the case at all, because there's a lot of good that's going to come out of this, and a lot of programs that are very important, new programs created for areas that haven't been addressed before, and we're starting to see our labors bearing fruit. We're starting to see that maybe, just maybe, we're starting to make a difference and possibly turn a corner, especially in areas that have been neglected for far too long. One of those is recovery support services. We all know people who go through treatment and recovery often have time, often once they're done with their treatment and they're in recovery, they may need job and vocational training. Well, there's a $4 million program for that, for people in recovery to receive vocational training. That's not a lot of money, but it's just a start. We can hopefully grow that pot. We're going to see a $25 million, we saw a $25 million loan repayment established by the Support Act. This is for people who wish to enter the SUD treatment workforce. They would apply to HRSA for this loan repayment program in exchange for up to 6 years of service in an underserved area to provide substance use disorder treatment. You heard me go on my little talk about the appropriations process. So while the bill authorized $25 million for this loan repayment program, the president's budget and Congress only agreed on $12 million. So right away, cut in half. It happens, but it's a loan repayment program that will hopefully grow the workforce to a size where it's a lot more efficient in underserved areas. There's the B Corps program, Building Communities of Recovery. This was created by the Support Act. Originally it was created at $6 million, and It's been increased to $8 million, and this will help recovery support services. There's going to be a new technical assistance center for peer support workers that was funded at $1 million. There was a $20 million program to the Department of Labor to stimulate the workforce because of the economic effects of the opioid epidemic. A lot of people don't know that, but the opioid epidemic, when you start talking about lost work, lost productivity, the burdens on the economic system due to child welfare costs, whatever, the cost is severe. So the Department of Labor was given a $20 million program to try and invest in areas that are hardest hit by the opioid epidemic and stimulate with job growth in those areas. So a lot of innovative good things coming out of the Support Act. It's just not as simple as, hey, we wrote a bill to solve the opioid epidemic and we passed it, ergo it's solved. It's just, we wish it were. That last program I mentioned, the Department of Labor, I find that really interesting because those of us who work on this issue, we're usually pigeonholed into two areas. One is criminal justice and the other is health. And why? Substance use, addiction, it's a health issue. Also, obviously there is a criminal justice aspect to it, unfortunate as that is. But we all know that substance use disorders touch every segment of society, including the workforce. So this program, the Department of Labor, kind of reflects that. Hey, we are not just about health. We're about labor. We're about schools. We're about housing. It really touches every segment of society, and certain parts of the bill sought to address that. So you can see what the Department of Labor is seeking to do is implement innovative approaches for addressing economic and workforce-related impacts of the epidemic and provide training and employment services, not just for the general workforce, but potentially, train people to be part of the opioid treatment or substance use disorder treatment workforce themselves. It's a really good effort. This is the reason I highlighted this is because I want to show you that there were aspects of the Support Act that we found to be innovative, original, helpful. It's not just the same old, same old. There is some innovation in the Support Act. There was also something in the Support Act on recovery housing. Those of you in California may be familiar with Representative Judy Chu and BHAP, along with one of its partners, CCAP, the California Consortium of Addiction Programs and Professionals. We've worked with Judy Chu's office for a long time on recovery housing. That was an issue addressed in the bill. It mandated SAMHSA to issue guidelines for recovery housing around the country. Now, here I'm going to give you an example of both the good and the bad. This was good in the sense that we always believed that there should be some kind of guideline for recovery housing on a national level. And while the federal government doesn't really have the power to do any national regulation, it's the states that would do that. They can have influence. That's why it's guidelines rather than regulations. But the problem was that once the legislation was done and written and SAMHSA got their marching orders and said, hey, develop these guidelines, it's in SAMHSA's hands. And SAMHSA stepped up to the plate and didn't fare well. Swing and a miss is kind of the terminology I use. Their guidelines were incredibly clinical, and they really did not reflect a working knowledge of what recovery housing was meant to accomplish. There was a lot of focus on MAT. They did not mention NAR, the National Association of Recovery Residences. They did not mention the NAR standards, which are the gold standard for everyone in the field. They did not mention them once. So the reason I bring them up is not only because recovery housing is an important issue to all of us, but I want to show you how when legislation is written, especially something as complex as the Support Act, it's not over when it's over. The bill is signed, it's law, but it's not over. You have to keep working aspects of the bill to make sure the processes that were set in motion through the bill's creation continue on the right path. So because what SAMHSA, the document SAMHSA released was a first draft, CCAP and BHAP partnered with the National Council of Behavioral Health, a very large organization in Washington, D.C. We met with the authors of the bill. We met with other congressional offices, and we tried to bring as much pressure as we could to bear on SAMHSA to fix it. So when their second draft was released and their final guidelines were released, lo and behold, they referenced the DAR standards. There was a better understanding of the purpose of recovery housing. It wasn't perfect, but they did a slightly better job. So what this illustrates, as I said, was the Support Act, like a lot of legislation, lives and breathes. Maybe you've heard that in reference to like the Constitution. It's a living, breathing document. It's not just, it's not a monolith. It's not inanimate. Any piece of legislation that sets something in motion, you've got to make sure that the motion continues. You got to keep moving the ball down the field. Maybe there will come a time where we want to revise these standards, where we want to go back to SAMHSA and say, hey, you've got to change with the times, change with the markets, evolve. There is constant opportunity to keep going back and saying the legislation stands for this purpose, and we can continue to make it work in lockstep with what's going on in the field. As the markets change, as the landscape changes, you've got to keep assuring that legislation that governs that continues to change as well. Now, you'll remember what I said about how long some of this can take. A lot of what was in the Support Act follows along the lines of what I said about SAMHSA's guidelines. There's a lot the federal government can do, but there's a lot they can't. The federal government can't mandate as many changes as people would like to think they can. But what they can do is ask agencies to issue reports so they have information to act on. So for example, the Support Act, CMS was instructed to produce several reports. CMS is the Center for Medicare and Medicaid Services. So for the first time, Medicare began paying for methadone treatment as required by the Support Act. CMS complied with the requirement in the law to publish within a year of the law's enforcement the first report on SUDs using Medicaid claims data. They fulfilled that. However, numerous other provisions of the Support Act are moving at a very, very slow pace, almost glacial. There was a hearing last week before the Energy and Commerce Committee where a representative from CMS was being asked, where's this report? Where's this report? Within a year of passage of the Support Act, CMS was supposed to report back to Congress on their progress in various areas. There were no less than 4 reports that had still not been delivered, 6 months late. Congress doesn't like it when reports are late. So guidance documents that are necessary for states, hospitals, other stakeholders have not been sent. Grant money for educating medical providers, the grants haven't gone out yet. There has been no call for submissions. Mandatory reports are stalled. Just as an example, one missed deadline is preventing state Medicaid programs from helping incarcerated individuals with substance use disorders. Congress was waiting for that report. It has not been produced. So Congress is trying to pass laws about reentry and Medicaid coverage, and they don't have the information they were promised or they mandated to CMS. So things are moving very slowly in response to the Support Act. DEA has a lot of influence. DEA is responsible for a lot of telehealth governance. They were supposed to report back to Congress within 1 year of the passage of the act on new regulations concerning medication-assisted treatment and its role in telehealth. It has not been reported back. We're still waiting for that. These are just examples of what the Support Act, of what we're facing with so many different projects and so many different mandates and so many different expectations. It still hasn't quite come together yet. It's still finding its footing. And these agencies that are responsible for these reports promised Congress that they would have them by sometime in the spring, which prompted the chair of the committee, Anna Eshoo, of California to say, well, on my calendar, spring ends on June 19th. So that was a pretty clear message to the people who said they would have the reports in by the spring. I'm coming to the end of the presentation here, and I want to just sum up by saying, I think you've gotten the sense that it's good that we've addressed this problem, but did we take the right approach? And the way I could sum it up is what Congress did is they took a disease and a problem that is chronic and came up with a solution that is acute, that doesn't match. When you have pilot programs that last for 3 years, 5 years, 1 year deadlines for reports, that doesn't address the very nature of substance use disorders. You need a long-term plan for this issue. And when I say long-term, I mean pretty much in perpetuity. This is not an issue that is going away or even getting better anytime soon. And Congress, in my opinion, is still missing that boat. We need long-term solutions. And unfortunately, at the end of the day, I don't think that's what the Support Act gave us. It gave us a lot of good to build on in the future and a lot of good ideas and addressed a lot of neglected areas. But overall, it was not the game changer that we were hoping for. I want to say that, of course, we're not done yet. There's a lot on the horizon in Washington. There are members of Congress who are talking about what they're calling CARA 3.0. And maybe this time we will get to that comprehensive legislation. You know, we're talking about legislation that looks at the long-term aspects of the problem and its impact on society. How do we do that? We focus on recovery. There will always be more people in recovery than in treatment. If you are someone who goes through substance use disorder treatment, if you live a good long life, as we hope you do, you're going to be in recovery for many, many years, whereas treatment is a much shorter term. So what we need to do is hopefully the next time around, look at how recovery can have an impact on substance use disorder and the whole the landscape as a whole, and and the opioid epidemic. And the last thing I'll say is that well, I shouldn't say unfortunately. I hope, I'm sensing that Congress is finally starting to see that you can't focus on a single drug of abuse. It's not an opioid epidemic, it's an addiction epidemic. And whether it be crack, methamphetamine, alcohol, benzodiazepines, whatever it may be, we need to look at the roots of addiction. The Support Act was very convenient for many members of Congress because it identified a bad guy, and that was the pharmaceutical companies and distributors. It's your fault, you did this to us, and we're going to show you. We all know that's not the whole story. Did they exacerbate the problem? Yes. Did they blow up the problem? Yes. But there was opioid and drug addiction long before Purdue Pharma ever came on the block, and there's going to be opioid abuse and substance use disorders long after they're bankrupt and wiped off the face of the earth. So it's not entirely about supply. What Congress did in this case was they made it all about supply. When those of you on this webinar who work in this space know it really needs to be about demand. And hopefully, the next piece of legislation we work on, I'll be coming back to you in a year or two and saying, we finally got that piece of legislation that looks at the big picture and moves forward. And with that, I want to leave time for questions. So there you have my contact information and my Twitter handle. And you have the information to contact BHAP, and Angie will be happy to answer your questions concerning that. So with the time we have remaining, if there are any questions, I'll be happy to answer them the best I can.
Thank you, Andrew. While we wait to see if anyone has any questions, I want to thank you for presenting today. Thanks as well to everyone in our audience for participating. A reminder that a PDF of the slideshow, along with a link to the presentation video, will be sent out by email in the next few days. Be sure to keep your eyes out for it. As I mentioned in the chat room, this is not our first webinar on the opioid crisis. The links to the previous ones we've done will be sent out with this email so you can find them easily. Additionally, one of our advisory board members, Harry Nelson, has written a book on the opioid crisis, and our partner CCAP puts on an annual Western States Opioid Summit. If you want information on any of this, please just let me know when you respond to the email with your questions. Well, we hope that you join us for future BHAP webinars. You can sign up for our various newsletters, which include emails specific to upcoming events, for free at our website, www.bhap.us. This concludes today's webinar. Thanks again.